So we have been studying a number of different novel agents alone or in combination in the I-SPY 2 trial, now 2.2, where we have sequential blocks of therapy. And I think this will really be the future of neoadjuvant therapy for breast cancer that responds to chemotherapy and immunotherapy, because what you can do is basically de-escalate based on response or escalate based on lack of response. And we use our identification of response as a combination of MRI, a calculated functional tumor volume from the MRI, and then a biopsy of the tumor area identified by MRI in order to assess response. So, for example, in these 3-month blocks, if you've had an imaging and biopsy PCR, you can go to surgery and skip the next sequential therapies. So we tested in a group of patients who have mammoprint high risk, triple negative or HR positive disease, the combination of Datopotamab, deruxtecan, the Trop-2 ADC, and Durvalumab, checkpoint inhibitor. We also tested Datopotamab, deruxtecan alone. But I think the most interesting data came out of the combination, where our own developed immune signature imprint positivity correlated with very high PCR rates to just 4 doses of the combination. And then in patients who were HR negative, and of course they're all HER2 negative in this arm, also had a high PCR rate to those 4 doses. And interestingly, in patients who didn't meet the PCR criteria after those 4 doses, who went on to get the first half of KEYNOTE-522, so paclitaxel, carboplatin, and Pembrolizumab, the PCR rates were extraordinarily high, over 90% in these 2 groups of patients, where the efficacy was seen in high-risk, hormone receptor positive, immune positive disease, as well as triple negative disease. So I think that it tells us several things. One is that the ADCs are effective. They don't seem to be more effective than chemotherapy when given with a checkpoint inhibitor in these patient populations. But it's possible that you could give a relatively less toxic regimen followed by the first half of a treatment, avoiding anthracyclines, avoiding potentially the longer duration of exposure to immunotherapy, and have a high rate of PCR. And I think this idea of individualizing sequential therapy rather than using a cookbook approach, arm A versus arm B, is the way of the future.